Now we're going to discuss the mixed lesions. Certainly the mixing lesions can cause cyanosis or not cause cyanosis, depending on the degree of mixing. The big one that you need to know is the truncus arteriosus. Remember that your heart embryologically starts out as a tube which kind of coils on itself, then the endocardial cushions come into play, and the top part of that tube eventually splits off into two tubes. One is going to be the aorta, one is going to be the pulmonary trunk. Well, with the truncus arteriosus, and there are four types, but you're not going to need to know them, but with truncus arteriosus, what you really need to know is that basically what's happening is one tube is coming out of the heart, so blood is going to be mixed from the left ventricle and from right ventricular blood. And depending on the degree of mixing, you may or may not have cyanosis. The other thing to remember about a truncus arteriosus is they all have a VSD associated with it. Okay? So truncus, think of an associated VSD. Truncus is very common in DeGeorge syndrome. Now we've already talked about DeGeorge syndrome, and we said one of the common manifestations is a neonatal hypocalcemic seizure. So if they describe that, and they describe a murmur, and they describe the physical findings of a DeGeorge syndrome, you should probably think of DeGeorge syndrome and look for truncus arteriosus. They all need echocardiogram. If untreated, that increased blood flow can cause an Eisenmenger complex. So at the beginning, they may not have a lot of signs and symptoms because if there's not a lot of mixing, they will be pink, but there's still going to be a lot of blood flow to the lungs, and they can develop pulmonary vascular resistance problems. Once again, here we see basically there is your VSD and one big trunk coming out. Here you see the pulmonary trunk coming out, and here you see the aorta coming out. It's basically one huge vessel coming out of the heart, and that's why you have the mixing. On X-ray, you can see a somewhat enlarged heart, and also the relationships here of the aorta and the pulmonary are a little bit different. Look for a systolic murmur and a single S2 because nothing's coming out. There's really not a pulmonary valve. So look for a single S2, and you can have an enlarged heart and get your echocardiogram. Surgical correction is the definitive therapy. The next one is total anomalous pulmonary venous return. What's described with total anomalous pulmonary venous return on the chest X-ray is what they call the figure of eight or the snowman. And typically what happens with total anomalous pulmonary venous return is that the veins returning from the lungs take a different route back and don't necessarily empty out into the left side of the heart. They, one or all, if they're talking about total, it's all of the veins are coming back to the systemic circulation. So it's technically, it's a left to right shunt. Oxygenated blood is going back to the systemic venous circulation. But since it takes a very circuitous route to get to there, those vessels kink off and cause obstruction. So the blood then can't really go forward, and everything backs up, and then you shunt across an ASD, and that blood is then deoxygenated, and you get basically like a right to left shunt. Okay. Another one, again, the X-ray is the figure eight. The echocardiogram is the treatment of choice, or the diagnosis of choice, and the treatment of choice will be surgical correction. The hypoplastic left heart is kind of like a garbage can term for anything that causes a small heart on the left side. Usually it's a left ventricular outflow tract obstruction that can cause a small left ventricle. You can have like an aortic arch or an aorta that's not properly developed, and so the ventricle doesn't develop either. And that means that the right ventricle has to do all of the work. The right ventricle is just not built to do work pumping towards the systemic circulation, and therefore the patient goes into heart failure very, very quickly. You're basically working with just one chamber to do all the pumping to go into heart failure very, very quickly. You need to get an echocardiogram, and again, surgical correction is the way to go. Here you see a drawing, and again, there seems to be a very severe outflow tract obstruction so that the left ventricle is really, really small, and so the right ventricle has to do all the work. There's usually some kind of a connection, like an ASD. or adductus. Again, these patients go into heart failure very quickly. You can see on serial x-rays, you can see the heart just getting bigger and bigger on the chest x-ray. Many patients with hypoplastic left heart also have other anomalies such as kidneys and CNS problems. They will go into heart failure quickly. They need surgery quickly, and they have a very poor outcome. Here's a patient in congestive heart failure, an enlarged heart, hypoplastic left heart.